Why are operating theatre nurses so mean? I get the 3rd degree.
Yes, of course. People are grumpy normally, like everyone's grumpy in the world nowadays. But there are nurses that are a little bit grumpier. I think I'll try and do my best to answer it. So I'll allude back to the intro I gave about operating theatres. It's kind of like a factory setting. So all the settings have to be exactly the same for you to keep working with high efficiency. And so when something is thrown into the mix that reduces your efficiency or makes you perform worse at your job, then it becomes a problem. And so they have a certain way of working and they don't want that disrupted. So when you come and there's something not in their way, then they're a little bit unhappy. Hi everyone, I'm Leon.
And I'm Nicole. And this is Nursing a Couple.
We are your 2 favorite unfiltered nurses.
We are scrubbed in, switched on, and ready to dive into this week's episode, which is all about our specialties.
That's right.
We're going to be talking about my specialty of paediatrics and Leon's specialty of operating theatre.
Yeah, so I thought the first thing we wanted to do was just give an intro to each of these 2 specialties. Just a bit of context so you know what we're talking about.
Bit of insight.
Yeah. After that, we want to talk about some burning questions we really got for each other because much like you guys, you probably want to know a little bit more about each specialty. We've got some burning questions, then some myths about our specialties.
We're going to be debunking some myths.
Yeah, that's right. We're going to be mythbusters for a little bit. So thanks a lot for listening. And lastly, if we're going to ask each other, would you ever actually switch your specialties? That's a really good question because we've been in the same specialties for a while. Sometimes you want to try something different. So we'll see what the answer is there. So stick with us. So I guess, where do we start? I think, should I start with operating theatres? Talk a little bit about it?
Yeah, take it away.
Yeah, sure. So, operating theatres. I'm sure you've heard and seen in TV shows and doing operations, nurse, scalpel, syringe, all of this sort of stuff. And yes, while that does happen, it's not the entirety of it. So let me give you some context here. So theatres, or operating theatres, is actually a really large complex. You can think of it as a multi-stage kind of ward. You can say there's 3 wards or 5 wards. So you usually have the pre-operative phase where you prepare patients for surgery. Then they actually go in and do the surgery. And then you go and recover the surgery. So they wake up first, then they go to another area, and then they get discharged to the wards. So all of that is in the perioperative field, which is the operating theatres. So you can do one role or you can do a couple of different roles, really. Now, the way I want you guys to think about it is like kind of like a factory. It's not nice to put it in that setting, in those words, but it actually is a factory. Think about it like this. You have materials that come in, which is the patient, and then you have what you're doing to that patient. You're doing their procedure, fixing their hip, taking the cancer out, etc. And then you take them over to the next phase in the factory, who care for them, wake them up, and then take them home after. Now, of course, you have to make sure you're efficient with this. So you have to have everything as a system, everything is a process. That's why we ask these nurses that come to the theatres why this is done, why this isn't done, etc. So that's the factory setting of it. But it's not just a factory, of course. We're there to help people. We're here because people have cancer that they have to have removed, or some old lady has fallen and broken a hip and we actually need to fix the hip for her so she can go and play with the grandkids. So it's about helping people who are in a very vulnerable position at the moment for a very finite period of time. So we help them with operations, procedures. It's about the holistic care and patient-centered care as well. So yeah, I think that kind of encompasses it. Did I do a good job there?
I think so.
Yeah. Okay, cool. Well, now, can you tell me a little bit about paediatrics?
Yeah, welcome to Paediatrics. Toilet humour is rife. We sing, we dance, and we usually have stickers on our face.
Oh, nice. That
and
sounds
I think
actually
that kind
really fun.
of encompasses paediatrics.
Do you have clown doctors too?
Oh my God, I hate the clown
You hate
doctors.
the clown doctors.
Maybe a hot take, but I don't like clowns to begin with.
It's very weird. I know we haven't gotten to the burning questions, but I got a burning question now already.
Hit me.
Yeah. Like, they're doctors, right? They actually are doctors.
Oh yeah.
So they go to like medical school, 6 years, internship, residency, then they become a consultant and like, no, I'm going to be a clown.
No, they're not real doctors, Dave.
Okay. You can't do sarcasm,
Oh my
okay? So they're not real doctors.
Absolutely
okay.
not real doctors.
You said it so easily and so convincingly.
No.
Anyway, sorry. Talk about paediatrics.
Paediatrics, little humans, little developing, growing, learning, little things. But then you had cancer. So at times, it's not the happiest ward. However, I think we find fun in the littlest places. We look after children who have cancer. So this can range literally from newborns born with congenital issues all the way up to 18-year-olds.
So you're saying some children, like kids, can just come out with cancer already?
Yes.
Oh, Jesus Christ. They don't even have a chance.
No. Sometimes unfortunately not.
That's sad.
It is. It's sad. A very emotional job, but
that's why there's clowns.
That's why we have the clowns. Yes.
Okay, that makes sense. It's all connecting.
Not necessarily for the little babies, though. Can be a rough time for some families.
Yeah.
But we look after the little ones. We help them through chemo. We try and knock out the cancer as best we can, and then we send them on their merry way to live, hopefully, their best little lives afterwards. So it's not just the kids, it's the families. We're taking them on a bit of a journey. We hold their hands through potentially the worst period of their life, and we just try to make something awful a little bit better. So on my ward, we give chemo, we look after the complications that can come with cancer or can come with chemotherapy, those really severe side effects.
And so sometimes they get better sometimes, so
they
then
do
they
get
come
better,
back.
yeah.
Sometimes you see them back, sometimes you don't see them. You're happy when you don't see them back.
I love when I don't see my patients. When they're finished treatment and I see them once a month for their checkups or something like that, it's my favorite time. But when they are there, we try to make it as fun as possible.
Yeah. Oh, that's good. It's a little bit, I don't know. For me, I don't think I'd be able to do that. It's a bit distressing, I think. And whenever I mention my partner is in pediatric oncology, when you combine kids and cancer, oh my God, like that's really heavy, isn't it?
I'm a real killjoy.
Yeah.
At parties.
Yeah. Killjoy. Good middle name. Anyway, let's keep going. Let's talk about some burning questions we have for each other. Do you have any burning questions? You got to let us know. We'll answer it in another episode, of course. But we've got our own burning questions for each other. So, who wants to go first? Nicole, do you want to ask me any burning questions?
I can ask you my questions.
Yes.
My first one, and my most important one, is why are operating theatre nurses so mean? Whenever I go to hand over a patient, I get the 3rd degree. Y'all are grumpy sometimes.
I don't think it's because... Yes, of course. People are grumpy normally. Like everyone's grumpy in the world nowadays. But yes, there are nurses that are a little bit grumpier. I think I'll try and do my best to answer it. So I'll allude back to the intro I gave about operating theatres, right? It's kind of like a factory setting. So all the settings have to be exactly the same for you to keep working with high efficiency, right? And so when something is thrown into the mix that reduces your efficiency or makes you perform worse at your job, then it becomes a problem. And so, I don't know, they have a certain way of working and they don't want that disrupted. So when you come and there's something not in their way, then they're a little bit unhappy. I think that's one factor, one aspect of it. Another factor is, yes, they're just grumpy. Some of these nurses stay in the same, in my view anyway, some of these nurses stay in the same position for a very, very long time. And they are experts in their field. They know exactly what they're doing, which is by intention, by the way. The surgeons require nurses to be in that area for a long time so that they know the surgeon in and out, so that the surgeon has a good time himself. So yes, they want the nurses to act, behave, operate in a certain way. And when that doesn't happen, it doesn't go well.
You don't have to be mean about it.
I know. Yes, you don't have to be mean about it, but hey, people don't have to do a lot of things in the world, and they still do. And I guess maybe they just have low emotional intelligence, I think. They don't think of others. That's right. Low EQ. That's what I put it down to. Yeah. I hope you're happy. I hope you're happy with that answer.
Absolutely not. It's a rubbish answer. But is it because you guys are always so cold? Is that why? You're just sad and cold down there.
Maybe we're sad and cold, but maybe I'll give some context. Operating theatres are intentionally colder than other wards, mostly because I'll give you 2 things. Mostly because I've got 2 things, and then the joke as well. That's why the reason why.
Oh, my word.
So the reason is it's cold because the theatres are kept a certain temperature because think about it like this: the surgeons are wearing gowns for a prolonged period of time. Okay? So they have another layer of like encapsulated clothing on top of them. On top of that, they have giant operating lights shining on them for 2 hours at a time, give or take, for however long your procedure is. And so it actually gets really hot for them. It gets really hot. They're operating, moving this, manipulating this joint, doing this. They're sweating because they want to make sure they do
Someone's
this.
holding a leg up for 2 hours.
Yeah. So it's actually heavy, hot work. And so the operating theaters around have to be a little bit colder for them to be at a neutral temperature. So, and when someone external comes into the theaters, they say, oh my God, it's so cold in here. Well, yes, for you've been outside. We're in here, we're working, hashtag, air quotes, working. But yeah, we do have extra layers of sterile, clothing on us. Now I've got the joke. You want to hear the joke?
Hit me with the joke.
Okay, yes, the joke. The joke, this was given to me by a surgeon, by the way, so it wasn't my joke, so credits to the surgeon.
Don't at us.
He said that theaters are kept intentionally so cold because all the nursing admins in their 50s and 60s, they're all menopausal and they're all having hot flashes all the time, so the theaters must be cold.
I think all your surgeons are divas.
Yes, that is true. They are divas, I would agree.
Prima donna surgeons.
Yes, prima donna. As soon as you said that, yesterday I had to get something called the princess mat. You know what the princess mat is? They have their shoes, they're operating for like a 20-minute case, 30-minute case. The princess mat is a really thick piece of foam mat that they want to stand on so that they can do the procedure for them. It's called the princess mat. Yes, of their little feet, that's right. Yes. But hey, we can't complain, right? They're doing the surgery for you. Whatever it takes for them to give you the best outcome.
It's a high stakes environment.
Yeah, you kind of want to give it to them, right? So yes, turn the temperature down a little bit. Who cares? I think we went off track there.
A little bit of a tangent on there. Speaking of surgeons, actually, I've heard that every surgeon, not every, but like 99% of surgeons have a ritual or a ways of working or have these little superstitions that have to be done for their surgery to go well. I've heard surgeons are one of the most superstitious groups. Do you agree?
So I would say no. I would say it's not so much superstition. I would say it's just the ways of working, of ways of practicing. You got to give me an example for me to actually classify this a little bit better.
So a surgeon has a specific playlist that they listen to every single surgery?
No. There is, so for example, one surgeon I work with very often, won't say his name, of course, for confidentiality, but he does have a Spotify playlist that he does play in theaters, but the playlist is all random music. And while they do like the music itself, they like the artist, it's just in the background.
Okay.
But that's not really superstition. They don't think a surgery playlist on Spotify is going to improve the patient's, clinical outcome.
Okay.
Like, no, it's just like, hey, I want some music.
What about a lucky cap that they wear for surgery?
Some of them may have something like that, but that's hard. That's like a gray area. A lucky cap, no, like we're not supposed to have the same cap twice in theaters anyway.
What if you can wash it?
Yeah, there's rules and regulations around that. They're not really supposed to do it. But they would have, this is my surgery cap. This is like I'm in surgeon mode. I'm in my best mode. I'm in peak performance. I don't think it's more so superstition. I think it's more so maybe just, this is my cap.
Okay.
Yeah, like I can keep it in my locker. It's easy. I don't have to look for another cap anywhere. I'm just going to wear that.
Okay. Do you have surgeons who have to step with their right foot first into the theater, do a little jig, make a little... Nah. That's a bit... That's like crazy pedantic, superstition, ghost stuff. That's more TV than reality.
Yeah, that's more TV than reality. They are normal humans, just like us. Yes, they may have religious beliefs, or yes, they may do things slightly differently. But I think on the average, they're all just like normal. What I really want to get to, though, is they have, ways of working. Like, for example, the princess mat, okay? It's not really superstition, but because they want to make themselves more comfortable, they will step on this princess mat. Or they want to have a good time in theater. They're there for 6 hours. Might as well listen to some music. So it's okay. Nothing's wrong with that. So yeah, I don't think it's superstition. One thing.
God.
I keep going about this. I like my field.
You're passionate.
I'm passionate. That's right. That's the word. One thing is the surgeon, for example, always wants to be the one to start the timeout in theaters. So timeout is a process to eliminate risk. So as soon as a patient comes in, before anyone does anything, you read out the patient details, make sure you are the person in here. We are doing your specific surgery. You have consented. Everything's good to go. That sort of thing. So sometimes some surgeons will say, no, I'm going to start this. This is my patient. I'm doing the surgery, so I'm going to start it. No, and everyone else knows, no, don't you dare start the timeout. That's his thing. He starts the timeout. Oh. So it's not like a superstition. It's like responsibility. And it's like minimizing risk kind of thing.
I am a little disappointed that there's not a surgeon doing a little jig before he starts his surgery, but that's okay.
Yes.
My last burning question: how often are you taking things out of butts as an operating theatre nurse?
That
Weekly,
really depends.
monthly, hourly?
Maybe, I think, well, around the world, I'm sure there's something removed from a butt every second. Okay. But I guess let's give some more context. If you work in a private hospital, then you're very, very unlikely to be taking things out of butts. Things in butts usually get there as an emergency, or like you come to emergency.
A bit of a whoopsie.
Yeah, like it's a whoopsie, right? If it's not a whoopsie, you can usually get it out, okay? So it turns into a whoopsie, then you have to come to hospital. So in half of the hospitals, which are private hospitals, no, you don't get things out of the butt. But your public hospital,
General surgery, right?
Yeah, general surgery, yeah. So how often? I don't know. Depends how big your hospital is. Depends if you have an ED department. Maybe I'm applying too much logistics and too much logical reasoning to this. So I think to make you happy, once a week.
Perfect.
Once a week.
Love that.
Buttholes and things coming out of them.
Oh, gosh.
Yeah, and usually they fall on it, isn't that right?
Oh, yes. Always falling when making a salad at 3 o'clock in the morning.
In the bathroom.
Of course.
In the bathroom,
Of
yes.
course.
Because there's a lot of phallic objects in the bathroom. Anyway. Okay, I've got my burning questions.
Okay,
Now,
let's go.
I'm sure you guys listening have some burning questions, but let's listen to Nicole. So, Nicole's in pediatrics. I want to know, don't you get sick of the patients? Don't you get sick of the children? They're crying all the time. You can't give them a shot. They're like, no. You can't really reason with them, you know. It makes your work much more difficult. So, like, that's the first part of the question isn't it just much more difficult? The next part is, okay, sorry, you go.
It can be. Look, pediatrics has its moments, but on the whole, the average nursing intervention probably does take longer for pediatrics. However, I have been told I have the patience of a saint, and I think that's where the big difference is. It may take longer, but in my eyes, the kids need a little bit of extra TLC sometimes. Yes, you can't rationalize with them. You can't tell them that this is for the best, even though it's uncomfortable. They don't understand those things. So you do have to take things a little bit more slowly with a little bit of TLC sprinkles, but I still really love it. And
That's good. You gotta love your job still.
yeah. And for me, personally, I don't think it's any harder. I've worked in adults and pediatrics, and I don't think pediatrics is necessarily any harder. And I do have more time for kids because sometimes adults are just whingers, but the children usually have a reason to whinge.
Yeah. I get that.
Yeah.
Okay, so then my second part of it is you already said that it does take you a little bit longer.
It can.
Right, so that's a built-in expectation because nurses have stuff to do, okay? We're supposed to be very efficient at our job because there's always something to do for the patient.
We're task-focused people.
So yeah, we're very task-oriented. So with that being said, with children, you say it does take longer. So a job that's supposed to take 5 minutes or something now takes 20.
Can take 45.
Yeah, okay, great. Can take 45 minutes.
Yes.
So there's an inbuilt expectation that, it's okay, Nicole isn't being lazy at her job.
No.
It's just that this thing that was supposed to be done like an hour ago is still not done yet.
Yeah.
And you're not going to get in trouble, or your manager isn't going to say, your performance is poor, you need to step up your game kind of thing. That doesn't happen, does it?
Yes and no. So everyone knows a lazy nurse, I think.
Yeah,
it's like every other profession. There's some good, there's some bad. But with kids, there is a fine line between getting the job done and traumatizing them. So sometimes with an adult, you can kind of push through the fear or the worry. But for children, if you push too far, that leads to trauma. So I would say we probably do have a little bit more grace time.
And the way I think of it as well, it's like sometimes you can maneuver it a lot easier. So for an adult, he doesn't want something, you have to take an hour to try and convince him or say this is good for you. But for a kid, you leave it, you come back, put on some Looney Tunes or put on some cartoons, and then all of a sudden they're like, yeah, give me this, give me this.
Okay, it's Cocomelon,
yes,
Bluey,
yeah.
Paw Patrol.
See, this is what I mean.
Those are the sorts of things you have to put on.
Exactly my point. So your degree of convincibility is now increased dramatically.
The kids have more of a distractibility sometimes as well. Sometimes you can be, oh, look at the shiny thing over there.
Yeah, you don't really want to, don't take that out of context, okay? All right, I've got one more question. It's a lead-on question there. Yes, sometimes it takes longer, sometimes it takes shorter, but
Little people, like babies.
you mean midgets?
Babies are probably quite easy in a way because while they do scream, like if we're doing a dressing, they might scream, but we can hold them in the position that we need to a lot easier. Doing the things that we need to do can be a little bit easier when they're younger. But yes, when they get to 3 to 6 and they're just becoming aware of themselves, they're becoming more aware of the world around them, things can get a little bit trickier. And then they start to associate things. So they associate the hospital with painful procedures or discomfort or something that makes them feel yucky, something that makes them feel sick. So they don't like coming to hospital and they're in a bad mood already.
Or they have you as their favorite nurse and they're like, yeah, I like Nicole. She gives me the lollipop.
Yeah, well, we give them all lollipops.
Right. That sounds like bribery to me.
Absolutely.
Yes,
that is Paediatrics 101
yes,
bribery.
See, this is the thing. I can't do that with an adult. Like, I can't try and give an adult a lollipop and then jab you. Let me stab you.
We also have rewards for them.
Yeah.
Like stickers and toys and things like that. Yeah.
Very different. Very different.
But yes, but as they get older, as they get over, 10 or 12, you do have that ability to reason, rationale. Tell them that, or this procedure is going to take 2 minutes and that's it. And then we're done.
Yeah.
And that's much better than trying to draw out and stop us doing what we have
want a
to.
lollipop? Hey,
we can just
here.
do it really quickly and then it will be over.
Look over there. Look over there. Nice. So we got some burning questions for each other. Now, I know time's going on, so let's try and do our last segment here, which is about some myths about our two specialties, Paediatrics and Operating Theatre. So just like with anything else, we're going to be some Mythbusters and we're going to try and give context of my first myth to Nicole, and if you can debunk this or not, is, are children's meds really that much more difficult than everything else? It has to be way more precise. Won't someone think of the children? Safety is like really high in children.
Yes and no.
Well, that doesn't help me.
I'm getting to it. It's not harder. You just have to do like an extra calculation. Adults can be quite standardized. So 99% of meds are weight-based, so per kilo.
Yep. And most adults are between 50 to 100 kilos, whatever.
Exactly.
Yep.
So you can sort of standardize adult doses.
Yeah.
But children, because their weight fluctuates and different age groups are different weight ranges, you do have to double check your work.
Yes.
But that's why we have double checking in pediatrics.
That's right, yeah. Well, we have double checking meds in kind of every profession.
Yes and no.
nursing,
so in pediatrics, currently, it is changing, but currently, every single medication you give, IV, oral, doesn't matter, you get it double checked.
Even nurse-initiated paracetamol.
Yes, double checked.
Interesting.
Double checked, double signed.
Right.
And in adults, it's not like that. You can do single check medications.
So to answer my question, it is a little bit...
I mean, you have to take an extra step. It's not that strenuous, I would say.
Because, for example, in theatres, it's very easy. The standard routine for a pre-op paracetamol is 1 gram of paracetamol for adults. Easy. But you can't really give 1 gram of paracetamol for a 3 kilogram neonatal patient
yes, of course.
Versus
Pediatrics
15-year-old kid.
Pediatrics is 15 per kilo.
15 per kilo.
15 milligrams per kilo.
Of paracetamol. Sure.
So if you have a child who is...
Who is 15 kilos?
It's 15 milligrams per kilo, so you just have to quickly do that.
Yeah. Check it with me.
Check it with you, and then throw it at the child.
Yes. And then hopefully they catch it in their mouth.
Hopefully they catch it in their mouth.
Okay. Which is hard with children, because it might take longer.
It is something I've done, though.
Okay. Anyway.
Chucked it up like a grape.
Next myth. What do you got for me?
Another myth that is rife in pediatrics is that they're just little adults. Absolutely fucking not. Sorry, there is a bit of swearing on this podcast.
We're unfiltered.
Unfiltered, that's right. Yeah, they're not little adults. There's different physiology, there's different development. It's not just...
They're little shits.
It's not just what you do for an adult on a smaller size. It really is very different. So if anyone ever tells you that children are just little adults, give them a quick slap.
Cool.
One thing I've always associated with you and the operating theatre is it could be a little bit easier because your patients are unconscious. Is it true? Is it a myth?
Yes and no. See how that feels? So yes, for the yes part of it, yes, the job is easier. The patient is asleep, which means you can manipulate them in any which way you need, do anything you need to. with the implied consent, because they gave full consent for whatever we need to do for them in that surgery. So yes, it is easier. They are asleep, but at the same time, we are still working, right? It's not like they're asleep and they're just sleeping and nothing else is happening. They're going to wake up 3 hours later. No, they're asleep because we're doing an operation for them. So we are actively giving them medications to keep them asleep, to first make them go to sleep, keep them asleep, then wake them up. And however long that takes, lots of meds are needed in that time, That's just on the top end of it. On the bottom end with the surgeon and the surgical nurse, you're actually doing a giant procedure. Lots of instruments, lots of counting, lots of, holding this, passing this, chiseling this, cutting this, cauterizing that. So no, and yes, it is a little bit easier, but also no, we're working. Otherwise, we wouldn't be there. We wouldn't exist. So there is a job that we're doing. The anesthetic nurse, maybe you can make an argument that they're not doing as much, but they are still working. Like, I'm still monitoring the patient vitals. I'm still getting medications for the anesthetist to push. I'm still waking up the patient, still getting the bed for the patient to go onto after. Like, all of this sort of, as I said, it's like a factory, right? They come in, you prep everything around them so that you can then do exactly what you need to. So yeah, we're still working. So it's not like it's easier. Yeah, maybe it's a little bit easier, but not easy. I think that's where I want to go.
That's fair enough.
Yeah.
Have you heard any other myths about the theatre? Like, what is the one thing everybody asks you at parties?
That the OT nurses just pass instruments.
Also, the surgeon says scalpel and you give them the scalpel, and there's no reasoning behind it.
Well, kind of, yes. Because the surgeon is the one doing the surgery. He knows exactly what he needs. So when he says something, you give it to him.
But you give it to them in a certain way. There is a certain skill.
Yeah, definitely.
Passing an instrument.
Yeah, so one job, the scrub nurse. Yes, they don't have much patient contact, but their job is very technical. They have to understand what the surgeon is doing with their hand and how to pass that instrument in that hand immediately so that they can use it. Think about it like this. You have a pen, you're going to start writing something. You don't pick up the pen upside down and start writing. No, you pick up the pen at a specific angle and put it in your hand so that the top finger is touching here and your thumb is touching here so that you can start writing right away. It's easy for you to do that to yourself, but there's two people involved here because the surgeon's looking at your wound. The scrub nurse has to put that thing in your hand the certain way you're going to use it.
Yeah, because the surgeon's not necessarily looking at the scrub nurse, is he?
They put out their hand and then you put what they need inside it, and they grab it and they start using it immediately. They don't have to fiddle around with it, turn it upside down, turn it this way. That's your job. Your job is to anticipate them. So yeah, the myth that OT nurses just pass instruments is, yes, that is technically true. Well, pass instruments, get instruments ready, clean instruments. Yes, they do a whole bunch of stuff with instruments, but it's also a bit more complex. And
I'd say we can debunk that one.
Yeah, I think so too. Yeah. Awesome. So I think we've shared some myths. I think we've talked about 2 different specialties, but I got one last question for you, Nicole.
Mm-hmm.
Would you actually ever switch to another specialty? Do you want to come to theatres? Do you want to do some recovery?
Absolutely not.
Oh.
Couldn't deal with the attitude of surgeons.
What if you were in recovery? You didn't have to talk to the surgeons.
Maybe then.
Maybe
then.
Oh, guys, sounds like we can get Nicole into recovery. Yes.
I don't think so. What about you? You've spent your entire career in a theatre.
In theatres, yeah.
Would you ever move out?
Would I ever switch? I think...
Is there something you think is less skills, more chills?
Yeah. I don't think there's a good enough reason for me to leave where I am now. But I can see there is a pathway out of doing another specialty. And that specialty is probably ICU nursing, because they are just, in my view, just very good at their jobs. Excellent, exceptional at their jobs. They have to know absolutely everything about the one patient in that room for 8 hours. And that I like. It's not so factory based. It's not so in and out. I see my patients for however long the surgery is, 20 minutes, 1 hour, done.
That's it.
Yeah, so I like that maybe you get to know the patient on a truly molecular level, and you're like, we need to do exactly this for this patient.
So if you had to switch, it would be to ICU.
ICU, yes. Mm-hmm. Not to ED, too hectic, too chaotic.
Too chaotic.
Not
Control
to children.
Chaos I could do in ICU.
Maybe that's an HDU then.
Pure chaos in ED.
Yeah, interesting. So, awesome guys. I want to thank you for listening to another episode of Nursing a Couple.
Join us for our next episode next week.
See you next shift.